So today I'm going to talk a little bit about surgery and small cell. We're going to go do a whirlwind tour about a lot of the major small cell lung cancer topics, including a little bit about history. So we'll give some background, look at some landmark studies, advances in chemo, and the different kinds of studies and literature that's out there. So as you all know, lung cancer is the most common and lethal cancer worldwide. And small cell lung cancer accounts for about 14% of all lung cancers, including 224,000 small cell lung cancer deaths worldwide in 2012. The reason why this is from 2012, there just hasn't been that many new updates worldwide for these numbers, but it's probably about the same, if not more. And you can see that compared to all these other cancers, from gallbladder, kidney, thyroid, and leukemia and multiple myelomas, small cell definitely is impacting a lot of people. So we'll talk about some of the historical studies. Basically, in the past, surgery has not been indicated for the treatment of small cell lung cancer. And that's because of two large-scale randomized trials that were published in 1973 and 1994. The first one, the one that was published in 1973, was led by John Scadday. And you can see from this picture, you get a sense of how old that study was. He was born in 1907, and he became a founding member of this Medical Research Council committee that was set up in England in 1946 and really pioneered a lot of the treatments. But as you see in surgery, there really wasn't much progress in that area. So this was the first analysis and first report of surgery and small cell with regard to the trials data. And it was published in 1966 in The Lancet. It was titled Comparative Trial of Surgery and Radiotherapy for the Primary Treatment of Small Cell or Oat-Celled Carcinoma of the Bronchus. And the inclusion was just any small cell cancer that was diagnosed by bronchial biopsy. This was way before the era of CT scans, and even chest x-rays weren't that good at that time. But this is the instrument that they used for the bronchoscopy. It was a rigid bronchoscopy, so not a flexible bronchoscopy. And they had 144 patients that were assigned to surgery or radiation. And not that many people actually were able to complete resection, less than half. And 32% had thoracotomy performed, meaning that they open up the rib cage and take a look at the lung, but they did not get surgery. And then 18% just never even went to the operating room. And then 15% did not make it to the surgery date. In terms of radiation, most everybody was given radiation, as you can imagine, 85%. And these were the survival curves at that time. So as you can see in the x-axis, it goes from 0 to 24 months. And at the beginning, the trial, everybody was still alive, but quickly within 1 year, most patients did not make it. And then in 2 years, it was virtually nobody was still alive at that time. And then they didn't really see any difference in the radiation arm and the surgery arm. So that was the first trial. And you could just see the numbers that were still alive. One person was still alive in the surgery group at 5 years and 3 in the radiation group. Because of that, there really weren't too many trials in this area for another 20 years. And this was, what I'm about to show you is the data from 1994 that was published by the Lung Cancer Study Group. The inclusion criteria for this is also people who are diagnosed by bronchoscopy. And the treatment regimens were chemotherapy first, followed by surgery, versus chemotherapy followed by radiation. And 146 patients were randomized with 70 to surgery and 76 to no surgery. The surgery group had a better resection rate this time. It was 83%. So if you recall, last time it was less than half of people who were assigned to surgery actually got surgery. This time, most of the folks actually got surgery. The median survival still it was better than it was in the 70s, but still only 15 months. And in the no surgery group, it was 18 months. And 2-year survival was 20%. So these are the survival curves, and basically completely overlapping. So showing that there wasn't a difference in surgery versus radiation. And because of this, it was typically thought that prognosis of limited stage small cell was extremely poor. Limited stage meaning that it hadn't spread to the brain and other organs yet. And these 2 major randomized trials did not show benefit of surgery for limited stage. And this is Thomas Shields. This is a quote from Thomas Shields, who was a thoracic surgeon. He said that surgical intervention for this disease fell into disrepute for many years. And so we'll talk about what has changed, though, and go over advances in chemotherapy. So if you remember, the trials I showed you were published in 1973 and 1994. But there have been a lot of advances in chemotherapy over the past 50 years. Combination chemotherapy agents such as anthracycline-based chemotherapy that were developed in the 1970s, and then in the 1980s, you had platinum-based chemotherapy and chemotherapy combined with thoracic radiation. And then in 1990s, there was this concept of early concurrent thoracic radiation with chemotherapy. So basically giving radiation with chemotherapy at the same time, and also prophylactic cranial irradiation, giving radiation to the brain for those folks who had good performance status. And the initial studies in the 80s started looking at people who were treated with etoposide and cisplatin. These are chemotherapy agents. And the survival curves are starting to be a little better than what you saw in the 1973 report. In the early 2000s, this is when you had the results from the Norwegian study group and the Japan clinical oncology study group. This was from the Norwegian study in 2002, where they had treatment regimens of etoposide and cisplatin versus cyclophosphamide, epirubicin, and vincristine. And you can see that with the cisplatin etoposide group, it was better. And that's why even to this day, cisplatin and etoposide is a mainstay. And then this question of concurrent versus sequential chemotherapy, basically showing that this was testing whether or not you give chemotherapy and radiation at the same time, or you give it following each other. And with concurrent chemoradiation, this line, the survival curve, is better than the sequential chemoradiation curve as well, both in terms of the overall survival, which is the figure on the left, and progression-free survival, which is the figure on the right. So now we're going to jump to some of the non-randomized data that we're now starting into 20 years ago, where folks were looking at a multimodality approach. So for example, for stage 1B and 2A, small cell lung cancer is giving cisplatin etoposide chemotherapy regimen and then surgery, or for folks with higher stages of disease, getting the chemotherapy followed by radiation, then by surgery. And the folks who had the surgical arms were doing better here, including in these survival curves as well. The left side is event-free survival for resected stage 1B to 3B, and on the right is the survival curve for 2B, 3A, and 3B combined. And so this is actually much better than the 1997-3 and 1994 studies, where even about 5 years out, as you see here, 50% of the patients were still alive. So very encouraging data back then. But there are still very few prospective non-randomized data on surgical treatment of small cell. And although it's promising that study that I just showed you introduced the possibility that surgical treatment could be an option for limited stage small cell. So I will fast forward about 15 years and show you some research that I did when I was research fellow and resident, looking at national databases. So this is a study we published in Animal Surgery about 5 years ago where we looked at surgery, which is the blue line, versus concurrent chemoradiation, which is the red line. So concurrent chemoradiation being the best non-surgical treatment. And this was a remarkable difference where you could see this really big gap between the survival curves. And so at 60 months, the 5-year survival was approaching 50%, which was way better than we've ever seen before. This is looking at national data from the National Cancer Database. And so you see these numbers are much higher as well, 681 patients, because we're looking at nationally what's going on in the US. We did what's called a propensity score match analysis, where we tried to make sure both groups were equally balanced with regard to their baseline characteristics. So to avoid having a comparison when one group was way older than the other or one group was way sicker than the other. And you see that even after doing the propensity score match analysis, there is a much improved survival curve in the blue line, which is the surgery group. I should say that this is surgery followed by adjuvant chemotherapy. So this is not surgery by itself, but it's surgery with chemotherapy. And then looking at the multivariable analysis, that is adjusted hazard ratio was 0.58. So with the hazard ratio, the way to interpret this, anything less than 1 is really, really good. So surgery, the adjusted hazard ratio was 0.58, meaning that surgery was associated with much better survival in this analysis. I also looked at long-term survival after surgery for N1 disease. The previous analysis was for N0 disease, so folks who had no disease in their nodes. This is looking at folks who had disease in the N1 lymph nodes. And you can see here with the blue line, it's still better than what is in the red line. The red line is the no surgery group, it's the concurrent chemoradiation group, and then the blue line is the surgery group. This is after propensity score match analysis, where we made sure to have both groups be well balanced with regards to their baseline characteristics, and the blue line is better than the red line. Surgery was associated with improved survival with an adjusted hazard ratio of 0.74, meaning that it was associated with better survival. So because of my work and also those of others, surgery is now recommended for early stage, so stage 1 small cell lung cancer. The question still remains of what is the best treatment for after you get surgery, and that's something I also have been studying over the years. The NCCN guidelines recommend adjuvant chemotherapy for surgery with early stage disease. The NCCN stands for National Comprehensive Cancer Network, which is organization that everybody turns to for guidelines. And adjuvant chemotherapy just means chemotherapy that you give after surgery. And NCCN also recommends prophylactic cranial irradiation, so radiation to the brain if patients are healthy enough for that after you get surgery and after and alongside chemotherapy. And that recommendation was from a study that I did, published now 8 years ago, looking at what are the best strategies after surgery. And so in this case, the red line is the adjuvant chemotherapy line. So these are all patients, these patients all got surgery, but the idea was, let's see what happens if they have adjuvant therapy. So let's see what happens if they have treatment after surgery, which is the red line, versus no chemotherapy after surgery, which is the blue line. And you see that there was a noticeable difference in improved survival with adjuvant chemotherapy. I further broke it down between adjuvant chemotherapy, which is the green line right here, adjuvant chemotherapy with radiation to the brain, so with prophylactic cranial irradiation, versus many other different types of treatment strategies. The red line here is just adjuvant chemotherapy alone without radiation. And it does seem like adjuvant chemotherapy with prophylactic cranial irradiation is the best treatment strategy. Folks do the best with the highest, with the best survival curve. And at 5 months, at 5 years, the overall survival was about 70%. And looking at the adjusted hazard ratio numbers, the way to interpret these is anything under 1 is good, so and associated with better survival. So chemotherapy is good with after surgery. It has a ratio of 0.78, but if you can do chemotherapy with prophylactic cranial irradiation, that's even better with a lower hazard ratio of 0.52. So in summary, patients with pathologic stage T1 to T2, N0, M0. So these are tumors that are, generally speaking, less than 5 centimeters with no nodal disease. Giving chemotherapy after surgery and chemotherapy with radiation to the brain is a good strategy. Now, we're moving on to 2024. This is an analysis that my group did looking at the number of small cell lung cancer resections through the periods of 2003, which is way at the very left of the graph, to 2018 here. And you can see the number of resections for small cell are actually going up. So in 2024, if you extrapolate this, it's probably even higher. So it's over 1,000 nationally. This is the US national data. And that's probably because of lung cancer screening and also because of the increasing use of CT scans. More and more people are getting CT scans for different kinds of evaluations, such as somebody has pneumonia and they go to the ED, sometimes they'll get a CT scan. Sometimes if they're getting some kind of workup for the heart, their doctors will order a coronary cardiac CT scan, and that will pick up some kind of small nodule. And so this is probably why the number of lung cancer resections for small cell are going up. And many of you know already about the studies about immunotherapy for small, extensive stage small cell. So Caspian and Ion Power, this is with durvalumab and atezolizumab. And then for limited stage that is not resectable, there's also Adriatic and NRG, which also testing durvalumab and atezolizumab. But what about immunotherapy for early stage small cell, operable small cell? And this is a study that I'm currently leading. It hasn't launched yet, but we're hoping. This took 4 years, 3.7 years, and we still haven't launched yet, but I'm hoping by March or April we'll finally be able to launch this. And this is a study looking at adjuvant chemotherapy with immunotherapy for patients with completely resected small cell lung cancer. And the study design would be for patients with T1 to T2, N0 to N1. So some nodal disease burden is okay, and also tumors less than 5 centimeters. If folks qualify and are in that inclusion criteria and they get surgery, the idea is to give them chemotherapy and durvalumab afterwards and see how that works. And hopefully the data from this study will serve as the starting point for a large-scale randomized trial for adjuvant chemotherapy and immunotherapy. And our goal is to get 65 patients for this study and to look at 2-year disease-free survival and also some other endpoints like safety and feasibility. So in conclusion, surgery for small cell, as we've talked about, there are those landmark randomized trials, but really new randomized trials are needed. That last randomized trial was 1994, which is 30 years ago. So we really need more randomized trials in this space. And it does seem like surgery for N1 disease can be safely performed, as well as surgery for N0 disease. So no nodal disease can clearly be safely performed. But the question of can we do surgery for N2 small cell, that's still being debated. And I think most centers would say no, but that's, I think, an area of investigation that's needed for the future. And chemotherapy and prophylactic cranial irradiation should be given following surgery for early stage small cell if possible. I know that not everybody can tolerate that because these treatments for some people are hard to take, but in general, if it's possible, that's probably the best combination. So thank you very much for your attention. And I'm happy to take questions, and I look forward to the discussion.
One of them you already answered, because I was wondering if you were talking about a lobectomy or if these are just resections of the lung. But when you say completely resected to get into that trial, what does that mean? That they just have completely removed the nodule?
Yeah, and we're not going to specifically limit it to a particular type of operation. I think that the original design, and the design that we first came up with, was lobectomy followed by chemotherapy and immunotherapy. However, we're going to broaden that to wedge resection, which is basically smaller lung operations, could be eligible as well.
Okay. And I know years ago, before you even did the PCI, you would have to respond well for X amount of time. So if you're looking at surgery first, what is the time span before they do the adjuvant therapy after the surgery?
Yes, that's a great question. So I actually haven't showed this data yet because it's not published, but it's a study that I'm currently working on, looking at what is the best timing for chemotherapy. And I think so. For this study, we're gonna be flexible and say anytime within 6 to 8 weeks after surgery. But it does seem like, because small cell is aggressive and more aggressive than non-small cell, that the closer that time interval you have between surgery and chemotherapy, the better. And so I think ideally, if it could be within a month, that would be even better. But for the purposes of this trial, it's a pretty flexible range.
So the first comment was, so there still isn't much new for extensive small cell. And I guess in regards to, I mean, there are trials, I know, but in regards to surgery, I guess there are not, correct?
Yeah, that's correct. I think so. My dream trial, so my grandfather passed away from lung cancer, and it was small cell lung cancer. And the reason why I wanted to become a doctor was because of being part of his care team and seeing what he went through. My dream trial has always been to see if we could really, now that there are a lot of advances in surgery, advances in chemotherapy and immunotherapy, to do a surgical trial where you compare surgery versus optimal no surgery treatment strategy. But that is probably not going to be in the near term future yet. I think we have to finish this adjuvant trial first, and then that hopefully will be the trial afterwards. So there's not too many new developments in that regard from a randomized trial perspective. But I think that with the increasing detection of smaller lung cancers, so for example, I just one of my patients I operated on in 2021, and we found the small cell at a very early stage. It was about 1.5 centimeters, and he's doing really well. It hasn't come back yet. So I think increasing detection and increasing earlier detection will be really important for the development of the role of surgery for small cell.
Yeah, hi, thanks. I was just wondering about metastasized small cell tumors. So, I mean, my understanding is the reason small cell can't be operated on when it's more advanced is because it's usually right in the middle of the chest and there's too much involvement with other organs, but also the fact that it's so aggressive. And I guess at the margins, you just have a big mess, kind of. But what about when you have a little tumor metastasized that is small cell carcinoma? How do you feel about using surgery on those? I mean, obviously, they can usually be radiated as well, but I'm just curious about this fear of operating on small cell and how far it goes.
That's a great question. Thank you for that. Are you referring to if there's maybe just one?
Yeah, good. That's a good point. Yeah, I just happen to have an oligometastasis, I guess it's called. So yeah, I just had one. So there was an issue. I was considering not doing chemo, just getting rid of that. And I did use radiation, but I asked about surgery, and my doctor said, "Oh no surgeon will get close to your small cell lung cancer." I'm like, "Yeah, but it's just under the skin on my back. It's just a little thing." So what do you say to that?
I think if it's oligometastatic, for non-small cell, for oligometastatic disease, you could do surgery for, and I think there's a general consensus you could do surgery for that, or radiation. I think for small cell, probably there are a lot of folks who would not want to operate on that. But me personally, I would probably consider it if it's small and just located in one spot, and if it's oligometastatic. So obviously we'd have to talk about it in a multidisciplinary setting with the medical oncology team and radiation oncology and the patient, and to come up with a decision. But I would consider it. This is an area where nobody really knows what the best answer is. And it is also something that I'm trying to study right now, looking nationally at outcomes.
So the fact that most surgeons would still not want to operate on such a tumor is, I guess that is because of the aggressiveness, like just the margins that you need. They just get nervous that they're not going to be able to get it all. Or is it just the notion that, oh, there's more, this is hopeless because there's more tumors, more metastases?
Yeah, I think it's probably that they would be worried that if small cell has already, if there is a spot that is metastasized, that the disease might be systemic, meaning that there are some small cancer cells everywhere in the body, and so taking it out would not necessarily help, meaning that they could take it out and then it could just come right back in some other place.
Right.
But surgeons at bigger academic centers would consider doing surgery for oligometastatic small cell, but it would be something that's very carefully discussed and just not something that you just go in there without really talking to a lot of people, because the last thing you want to do is give somebody an operation and then for them only to have it come back 3 months later, because it still takes time to recover from surgery and that recovery period. So if we could save somebody that recovery period and not have to have them experience the entire process of going through surgery and getting better, that's always an important consideration as well.
I'm going to go to Linda's question first. I was diagnosed in 2020 with limited stage, and I noticed that some people do use numbers, but I also am used to the extensive or limited. But I know that I think you're categorizing the nodules and things as 1 and 1B, correct?
Yes.
Okay. So she said she is limited, but they said no surgery. But I believe I had one spot, but they thought that I had one lymph node involved. Was that accurate? Oh, 3B. She just put 3B. Okay.
Yeah. So if it was stage 3B, then that means that the lymph node would be on the other side of the. So for example, if the tumor was on the right side, then the lymph node would be on the left side. The lymph node that had the cancer would be on the left side. So usually at this time point in 2024, I would say most people would not recommend surgery for stage 3B small cell at this point. And I feel like for myself personally, I probably would not operate on a scenario like that.
And just to clarify, it might have been 3A, but everything was on my left side.
Oh,
there was
okay.
nothing on the other side. It was just one tumor, and they thought that there was a lymph node. But that's why,
I think that, and this is an area where it's just, it really depends on the center's experience and also the surgeon's experience. I think for me, personally, I would probably consider a strategy of surgery with chemotherapy or chemotherapy with surgery if it was in if it was an N1 lymph node station. So basically, if the cancer had gone to the N1 lymph node, so not the N2 lymph nodes, I would consider that. And you'd have to take the entire picture into account as well. For N2, I think that usually with small cell, if it's N2, it's pretty extensive and the disease burden is large. And so usually you wouldn't consider surgery for that. But if it's, Linda, it sounds like in your case, it was just a tiny lymph node that lit up, right? I think I would probably consider a strategy of some combination of chemo and surgery in that particular case. Again, the caveat being like, I haven't seen your CT scan and things like that. So yeah.
I know is that they said that they were treating me curatively, and that there was just on the one side, like a tumor, small tumor, not even a big, like a large, but the lymph node, they said the oncologist was just like, nope, no surgery.
Yeah, the current guidelines though, like the standard of care would be no surgery, I think. So so they were correct in that. I just, having done a lot of research in this area, I've seen good outcomes, and so I would be I think I would, again, it does depend case by case, but I would be willing to consider it as long as we talk about it in a multidisciplinary discussion in tumor board setting with the medical oncologist, radiation oncologist, and the patient, and everybody is all on the same page.
Thank you.
I just wanted to mention I am non-small cell survivor, but I just wanted to say how great it is that the surgery is coming into the small cell field now. And I know it's really, really new, but I'm persuaded that's why I'm an 18-year survivor, because I had, surgery to remove my cancer, and then I had some adjuvant chemotherapy, and I think it's just great that it's coming to small cell now. And also, correct me if I'm wrong, but even though I understand there are some in the small cell space, there are some more surgeries taking place than there was previously in advanced, in metastatic lung cancer. But even in a small cell, there's not a lot of that. It's mostly for the earlier stages, right?
Yeah, that's correct.
And the other thing I wanted to mention, though, is the type of surgery. So when I had mine done so many years ago, they did the old-fashioned thoracotomy, which was a very, very hard surgery. And, on these, you said about 6 weeks is optimal, or maybe even less than that. Is that with an old-fashioned thoracotomy or the newer, minimally invasive surgery? Or could you just address that a little bit?
Yeah, thank you, Dusty. And with regard to surgery these days, most operations are, especially at the academic medical centers, but I would say even in community settings, most operations are done minimally invasively now. There's two main types of minimally invasive surgery these days. One is VATS, which you may have heard of, which stands for video assisted thoracoscopic surgery, and that's where you make 2 to 3 small incisions, just 2 to 3 small cuts, maybe each one this big, and you have a camera and long, thin instruments go into the chest and remove the cancer that way. The other one is robotically, where it is similarly, you have to make some small incisions in order to put these ports that then allow instruments to be placed that the robot can use. The surgeon is still manipulating the instrument, so it's not purely a science fiction world where the robot's doing everything. It's still the human who's doing it, but it's through the use, it's through the help of a robot. And in those types of situations, if you can do an operation minimally invasively, then patients can usually go home the next day or be in the hospital for maybe 1 to 3 days. But a lot of my patients actually just go home the next day after the operation. And so recovery is faster. And in that case, my hope is that folks can get the chemo within 6 weeks, if not even within 4 weeks of after surgery. But that it's a big step and a big advance since back in the day when everything was done through thoracotomy, which for those who are not as familiar with, it's quite a big cut, maybe like about a foot to a foot and a half, and then you have to break a little bit of rib and then spread the ribs apart, and so that takes a lot more time to recover from.
Oh, and I have another question. So tuberculosis is often coupled with lung cancer. Why is this?
That's a good question. I don't know the answer to that, and I'm actually not as familiar with tuberculosis with lung cancer. So I'll have to look that up and get back to you. So I've been fortunate in that in training and also in practice, none of my patients have had tuberculosis, but I wonder if sometimes it's also regionally in different places. There's more TB, and then you see that with lung cancer patients. But I've been fortunate that I haven't seen that.
Are there any other neuroendocrine cancers that the first line of treatment would be surgery?
I think the way to think about it is if anything has not spread to the lymph nodes yet,
okay,
for the most part, I think it should be operable. Like you should be able to take it out by surgery. And that is the preferred choice if somebody is healthy enough to go through that. If somebody's lung function is not good enough for that, though, then radiation would be a possibility. In a particular kind of radiation is called SBRT, which stands for stereotactic body radiotherapy, which is shining a focused beam of radiation to that area.
I'll have another question in the chat. Can radiation sometimes irritate the area and cause, and a new word for me, hemoptysis?
Hemoptysis.
Oh yeah, that is a new word for me.
Yeah. So I'm not a radiation oncologist. It is a very good question. I suspect that it could, but it depends on where so hemoptysis means you're coughing up blood, and it does depend on where the tumor is. So if the tumor is near a bigger airway, then that tumor starts to bleed, then you're more likely to have hemoptysis. But I don't know I don't know how often radiation would actually cause hemoptysis. That's another good question I need to write down and get to you on.
A couple more questions coming in. My extensive included a spot on my liver, which was gone after chemo/radiation, never in a lymph node. Could mine have been treated with surgery? Size was 8.3 centimeters.
I think generally guidelines would recommend no surgery in that case. But in 2024, I think in a multidisciplinary discussion, things could be different. Surgery is still difficult to recover from. It takes time, and sometimes it can really take a lot of time to recover. So, but generally, if somebody's younger and able to recover faster, then more aggressive treatments are considered, like more aggressive as in surgery. I would say, to answer your question, probably most people would still go with a non-surgical option, but in 2024, things could be different after a multidisciplinary discussion.
Another question. My doctor said I was limited if I have involvement in 2 lymph nodes. What stage am I?
It depends on where the lymph nodes are. If you have lymph nodes in the N1 stations that are positive, then that would be stage 2 usually. And it depends on how big your overall tumor is, but usually that would be stage 2. And then if you have lymph nodes in the N2 station, then that would be stage 3.
I have another question. I think you mentioned that for the limited, the standard would be PCI. Is that always done? Could it be done a second time if lesions are found later?
So PCI stands for prophylactic cranial irradiation, and prophylactic means you give the radiation before you see something. So in the case of prophylactic cranial irradiation, that means cranial, so to the head, radiation to the head, before there's any cancer that you see in the head. So in the brain. So I think that to to answer your question, usually prophylactic cranial irradiation would be given after surgery, and then within a time window of, I would say, about 9 months, because you have to factor in giving chemotherapy as well. And I haven't heard of anybody giving prophylactic cranial irradiation after a year or two. Usually if people are getting radiation to the brain after a year or two, it's because the cancer had come back and it had spread to the brain, I think.
And I have another question. I am one who they thought was non-small cell and did a resection. Then the pathology came back and it was small cell lung cancer. The surgeon wanted to take out the upper right lobe. I agreed to it, even though the pulmonologist said no. I had surgery and then had carboplatin and etoposide. That was in 2021. I'm in remission, but have inflammation at the surgery line that is there for a year. Do you agree?
I think this strategy of getting surgery followed by adjuvant chemotherapy for small cell for stage in head and spread to lymph nodes, I think that is standard of care now. And the guidelines would agree that that was the right thing to do. In terms of that inflammation along the staple line, I'm assuming you mean that it hasn't come back, but it's just something that you're kind of seeing by CT scan. And so just continued CT scan surveillance would make a lot of sense.
That was me. Yes, they had a big fight over whether they should take out the upper right lobe. The thoracic surgeon said yes, they did take it out. The pathology was different than what they thought it was. But I do get CTs every 3 months, and I have this. They're calling it inflammation. They thought it was a recurrence, but it's not because it's been biopsied twice, and they don't know why the inflammation is still there. But they're convinced it's not. It's getting smaller, so and they don't know why it's there. And I heard nothing in the end, nowhere in nothing else. I didn't have any cancer showing up in any of these glands or anything.
Oh, good.
So,
that's great.
But my pulmonologist still thinks I made a mistake, even though I'm fine after almost 3 years. I just saw him. He says, no surgery for small cell.
Oh yeah, that's well, I'm really happy that you did get surgery. That was absolutely the right thing to do, and that is something because I've talked about things where. Situations where you want to discuss with everybody and not everybody might agree, but I would say most doctors in the field who are either medical oncologists or radiation oncologists or surgeons, they would and are in the field and know the field, they would agree that surgery would have been the right thing to do. Surgery with chemotherapy would have been the right thing to do in your case. So I'm glad you went through that.
I have a couple more questions. In regards to PCI, is it suggested twice daily or once daily?
Yeah, that's a great question. I'm writing all these questions down that I don't know the answer to. I don't know the answer to that, but I will figure that out from our radiation oncologist. Barbara, I did want to maybe tease our pulmonologists. I love our pulmonologist at Mass General and the pulmonologist that I've worked with, but for some reason I've heard quite a few odd and weird recommendations from pulmonologists, and it's pulmonologists. I don't know why. One of the students that I had been mentoring, and he was for his medical school interview, he was telling the doctor who was interviewing him all the lung cancer screening outreach that he's doing, and the doctor was telling him why you shouldn't get screened for lung cancer, and he was a pulmonologist, and pulmonologists. I don't know. I've definitely some of the oddest things I've heard are from pulmonologists. But that said, I love our pulmonology colleagues, and the pulmonologists that I work with are fantastic. But I'll keep in mind, Barbara, your interaction as well.
Yeah, he still thinks. I just saw him a week ago. He still argues with me that I shouldn't have had that surgery, even though I've been in remission for 30 years. It's kind of odd, isn't it? Because he was proven wrong. He said, no, don't do it.
Yeah.
But yet my thoracic surgeon said, we really should do it.
Yeah.
That's funny, Dr. Yang, too, that you said about the screenings. When we first started doing this advocacy and fought to get a pre-screening for lung cancer, the medical community was against it. So
Yeah.
I can understand. Yeah, they were like, no, it's too many false positives. A couple of more questions. And I guess this is a comment, although it sounds like he had surgery. So not much can be done for stage 4 that spread to the brain. They took it out and now on immunotherapy. They
took the brain part out, I imagine. And that makes sense, and probably kept used chemo and radiation for the lung.
And I have another question. Why is it that some small cell lung cancer patients have scans every 3 months and others have them every 4 months? Is this an insurance issue? My doctor has me going for scans every 4 months, yet someone else I know has every 4 months.
That's also a great question. That is, it's not an insurance issue. I think it's a doctor preference issue. And that's something that I am also trying to study. I wrote a protocol to look at how often do you actually need scans, but it didn't. It did not get selected as high enough priority. So we'll revisit it. I'll certainly revisit that. But I think that 3 or 4 is completely reasonable.
Right. Oh, good. I had another question. When I complained about the 3-month intervals, my oncologist laughed at me and said, I can handle 4 times a year. So thanks, Maida, for the encouragement. What does N1 mean?
That's a good question. I think, I'm going to write that down too, because I think next time I need to just show a map of this. It's just the location of where the lymph nodes are. So where with N1, it just means it's closer to some of the blood vessels in the lung, the bigger ones, but it's not N2. N2 is very central, so very much in the center of the chest, and N1 is a little bit farther away from the chest. This is a little bit small of a picture, but you can see here that 2R, 4R, 4L, 2L, 7, 8, 9. These are all lymph nodes that are in the N2 station. The 5 and 6, these are N2 lymph node stations. And then 10 is farther out. It's more where my this little hand is. It's more a little farther out. It's less central and farther away. And it's our way of figuring out how advanced the disease is. So I started a nonprofit for lung cancer screening. It's called ALSI for short, the American Lung Cancer Screening Initiative. And every once in a while, we also have some big Zoom get-togethers, for example, for lectures and stuff like that. And I would love to invite all of you to come to that if you're free. So I'll probably talk more with Lynn and Montessa and Dusty about that in the future. So, but it's so great to see you all.
Well, thank you. Look, you're getting accolades. And so thank you for the work that you do. Thank you for focusing on lung cancer. And especially, sometimes we are the forgotten, as I call it, the stepchild. No more forget-me-nots, that people are focusing on small cell particularly. And we thank you.
Thank you so much.
Thank you very much.
Thank you.
Thank you.
Hey, take care. Have a good evening.
Bye-bye.
Bye-bye.